Hello everyone. Thank you for this wonderful opportunity to share this work with members and supporters of the Palliative Care and Nursing Ethics Hub at the University of Ottawa. And thanks to the Canadian Nurses Association for hosting this event and making it possible. So I would like to acknowledge the land from which I am speaking at McGill University. The Haudenosaunee and the Anishinaabe were the original stewards of these lands and waters. I pay my respects to the Gayengahaga, who continue to care for this land, and I thank the elders past, present, and emerging for their guidance in our shared learning. I've been working in palliative care research since 2002. I started with a focus in pediatric palliative care and quickly was drawn to the experience of grief and bereavement as an area needing more social science reflection. I'm a social scientist, I'm an anthropologist. And I have continued this fascination with and concern for the place of grief in palliative care ever since. Now, I was reflecting on the tone for this talk and wondering if it's too soon to muster an upbeat kind of talk in the midst of a global pandemic and certainly the Black Lives Matter movement. However, I don't think we can do this any other way. Susan and I are so inspired and passionate about grief literacy, and we really feel that now is the time to get people on board with a movement towards community-based kindness and compassion. That is not to say at all that people are not deeply suffering from grief and loss right now. They clearly are. The entire backdrop of our lives, locally, nationally, and globally, brings suffering into sharp relief, clearly. And this talk builds on that knowledge and endeavors to open a conversation that starts with and stays grounded in that backdrop. There is so much awfulness in the world right now, but I don't think it's productive to spend our time together going through the misery statistics and dying images that we are all doom scrolling anyway. So what we want to do is pull us upward and forward to contribute to imagining some alterations to our caring landscape. This is a palliative care talk to a palliative care audience. And so I feel it's okay, I'm amongst friends, to dare to criticize my own family, my palliative care family. So please bear with me as I suggest that some parts of our dear profession may need some attention. The development of palliative care has many important advances, obviously, we wouldn't be, celebrating this nursing hub. However, as a service delivery model, as a number of scholars have pointed out, some more gently than others, its development, palliative care's development, has also gone hand in hand with the undevelopment or underdevelopment of communities' capacities and abilities to care for the dying and the grievers. For starters, this image presents what specialist palliative care looks like in the global north, be it Canada or elsewhere in high-income countries. Now, according to Spernswald, after his decades of service to the WHO cancer portfolio, both the hospice approach and the institutionalized medical approach of palliative care has really failed to reach the majority of those who need it, covering only the lucky few through that tiny bit at the pyramid, at the top of the pyramid. Now, this palliative care development has and is happening against the backdrop of an epidemic of social isolation and loneliness. An epidemic that preceded but is exacerbated by COVID-19. Our societies are experiencing more and more social isolation, and we are living in worlds where loneliness is actually killing people. And even before COVID-19, this social isolation was becoming politicized and medicalized as a public health crisis, with the claim that it was causing morbidity and mortality equivalent to smoking 15 cigarettes a day. And in response, the UK created the governmental position for a minister of loneliness. And we can now add to this the world that we've created in which people are dying alone from COVID-19, and a world in which people are also grieving these deaths alone. So while palliative care has clearly made important advances, I don't want to downplay that, in how we're caring for the dying, we need to be self-critical as well. So the professionalization of end-of-life care means that palliative care is primarily orchestrated by professional carers with formalized care plans that rarely include the full range of family caregivers, and especially it doesn't include the extended informal social networks that are involved in care. It has become normal to pathologize dying, medicalize it, which disaggregates communities at end of life. And we can contrast that to the birthing movement, which has done the exact opposite. When a healthy baby is expected and born, communities mobilize. New parents are encouraged to seek out parenting groups, Facebook groups, informal social supports. People make casseroles. It's socialized to do so, and it begets a model of both formal and informal community care. And we can add to this list of kind of the challenges with how palliative care is now, this economic challenge of supporting specialized healthcare services. Journalist Andre Picard has likened accessing palliative care in Canada to winning the postal code lottery, because, for example, urban postal codes have more access than rural postal codes. And I would add that there's still even a diagnostic lottery, with cancer still getting more reliable access than other dying conditions, such as end-stage kidney failure or COVID-19. And then especially important for this talk is that palliative care seems to have forgotten, I don't want to say entirely, but I kind of feel it really forgets about grief. My epiphany began when I went to my first public health palliative care conference a few years ago in Ottawa, and I've gone to another one since in Australia. So the public health palliative care movement is really challenging conventional palliative care, challenging the notion that death and dying should be housed within clinical and institutionalized contexts, that it must be managed by professionals with increasing specialized expertise. And public health palliative care is also a movement that is supporting efforts to normalize conversations about death and dying by opening dialogue in public, civic spaces, be it in schools or faith organizations or parliament or even grocery stores. And what struck me and has really stayed with me is this one small phrase, the 95% rule. Now, according to Dr. Alan Kelleher, one of the key founders of this movement, people with life-limiting or terminal illness spend only about 5% of their time with medical and hospital or hospice specialists. That is, as much as 95% of their time is being spent with family and friends in their community, in their mosques, in their schools, in their workplaces, in their grocery stores, not engage with medical professionals or resource-intensive service delivery models of care. And yet, with our blinders on and well ensconced in our silos, we, me, the palliative care researcher, tend to focus mainly on this 5%. And of course, this is a rhetorical metric. I don't think anyone did the math to figure out this 95% rule. But regardless, this short phrase is the foundation of thinking about public health palliative care. How dying people are living and dying in their communities. Now, one of the endeavors of public health palliative care has been committed to bringing forth a community-based focus on death and dying. And at one end of the spectrum, this commitment is materialized by and through community engagement activities, such as through death cafes, many people have heard of those, or the Death Over Dinner movement, And this is all kind of framed in what's been called the death positivity movement. So it's promoting positive conversations about death and dying. And on the other end of the spectrum is community development. So not just engagement, but actual development, which more explicitly seeks individual and community change. And an example of this is death literacy. And that's been advanced by Noonan and colleagues in Australia. And it's not just about passive that's my other hat, death education. It's not just passive education. It's defined as a set of knowledge and skills that make it possible to gain access to understand but act upon end-of-life and death care options. Death literacy is mobilized through practice wisdom, that is the embodied experience of community members caring for the dying in their communities and sharing their experiences in order to improve access to the local death system. And while personally I find this construct particularly helpful to think with in this new public health palliative care paradigm, missing for me and many of my colleagues is again this explicit attention to grief. But what is grief? And why should we care? And how should we respond? So my conceptual frame for understanding grief is starting with the body. And that body could be an individual body. It could also be a social body, like a family or a community or a nation. And I've chosen these images with purpose. Grief in these images is being conveyed as ontologically embodied. That is, it's located in individual bodies, but it's also in the relationships among the living and between the living and the dead. So grief is an embodied response to loss, which is clearly multidimensional, and it affects all of life's domains: physical, emotional, behavioral, social, financial, spiritual, political. And if there is a silver lining to this pandemic, and don't get me wrong, I don't think there has to be, we certainly have seen much more public attention to death, dying, and finally, grief. But grief was there before the pandemic and continues throughout in ways completely related to, but also completely unrelated to the pandemic. And I don't have faith that this pandemic is going to make us all death literate or solve grief for us. Take this reflection from a colleague a few weeks ago. This morning, I read of Quebec's 4th death of a PAB, so an elder care aide, in the CHSLD. A father in his 40s here in Montreal. The opposite of grief. What struck me was how unfazed I was. Early on in the pandemic, I cried often. I cried when the first medical person died in Quebec. I cried when the first PAB died. I cried. It was healthy crying. Today, I read the headline and it was like flipping the newspaper on an average day. I read the article and his death may be on my mind. I may chat about it with a family member or a friend, but that's it. I fear that part of our new normal is the normalization of COVID-19 related deaths. The opposite of grief, it feels like an indifference more than a numbness to the news. It's just becoming normal to read of these deaths. Anyway, just wanted to offer that unsettling reflection on a Monday morning. So I've been thinking and writing about the denial of grief for a few years now, and thinking about what is at stake for grievers in the world that doesn't do grief very well. That world, as I've suggested, includes our world of palliative care. I personally believe that grief denial is doing much more harm in our communities than what many have labeled death denial or death taboo. That's a whole other talk. The denial of grief is a social phenomenon that has much at stake for grievers who end up living loss in entrenched social isolation because few people in their social circles know how to open non-judgmental, non-stigmatizing, listening spaces to help hold and support grievers. What's wrong with how we currently do grief? In our current model, the continuum seems to be, on one end, psychologizing grief and expecting psychosocial professionals to deal with it, fix it, or we leave the grievers to care for themselves in communities where the grief is experienced at best as uncomfortable and met with silence or awkward phrases such as, well, at least he died peacefully. And at worst, it's feared as if contagious, and so well-meaning neighbors cross the street to avoid coming in contact, coming too close to the grievers in case they'll catch it. The public health model of bereavement care was published in 2015 by Aoun and colleagues, advancing a conversation about supporting grief in communities. And importantly, this model builds on empirical research that shows that while specialized psychotherapy will always be beneficial for some grievers, especially the 10% high-risk category at the top of our pyramid here, it is not needed by the majority of grievers who can be well served by non-professional, community-based interventions. And there's even some research to suggest that over-treating grief causes harms. And further, what this model really helps us think about is that all people who are grieving, that's 100% of the triangle, benefit from compassion and non-judgmental social support in their communities, by which I mean workplaces and grocery stores. And this piece, the grief-attuned compassion and social support, is not something that our societies are very good at yet. So building on this model, coming from death literacy through to this triangle that I just presented you, we were working with an international team. So that's Susan and I have been working with this team within the International Work Group on Death, Dying, and Bereavement. And we've advanced this concept that we're calling grief literacy. Now, grief literacy starts with the premise that grief is often lived as lonely and isolated. And grief literacy aims to empower everyday citizens, individuals, networks, and communities to understand grief and to be empowered to support one another in it. This support is mobilized through everyday acts of kindness and compassion, including helping those at the top of that pyramid who are high risk and need specialized help to find professional services. And for those in the rest of the pyramid, a salient social response is community-based acknowledgement and validation. That is no longer stigmatizing the grievers and instead opening non-judgmental and supportive listening. So what do we mean by grief literacy? Well, we didn't actually coin this term. It does show up in non-academic internet sites and in actually one unpublished dissertation. But we've really tried to build this theoretical scaffold of sorts to start to give it some more kind of robust structure and a holding frame. So grief literacy lives in the individual in their capacity to access, process, and use knowledge regarding the experience of loss. This capacity is multidimensional. It comprises knowledge to facilitate this understanding and reflection, skills to enable you to act, and values to inspire compassion and care. But an individual is not an island. Ontologically, people are relational beings embedded in sociocultural contexts. And epistemologically, grief literacy is co-produced, it's co-lived, it's co-enacted in communities. Now, as a group of researchers and clinicians, our end game was important to us. That is, through this exercise of building the scaffold, we were searching for a utopia, something we could call a grief literate society. And so we expressly thought about grief and loss as not just about palliative care. Instead, we were more ambitious in our thinking outside of where the realm of palliative care to include these other kinds of components. So within grief literacy, we're thinking about multiple kinds of loss. So death, yes, but also non-death losses. So grief from divorce, grief from amputation, grief from tooth loss, grief from pet loss. We were thinking about who is experiencing the loss. So there's issues of gender, there's issues of age, like who died. So the relationship to the deceased. Again, gender and age comes into this. What was lost? Was it a person? Was it a pet? Was it a possession? Was it an identity? Loss of a homeland for migrants? Loss of a role as a spouse or a parent? We're thinking about when did the death or loss occur? How much time since the death? There's concepts like anticipatory grief. There's also the idea that grief doesn't have a timeline. Decades-old grief can still feel incredibly fresh. Where did the loss occur? The place of the living, surroundings, the relationship to other people. How did the person die, or did the loss occur? Was it through war? Was it through more stigmatizing deaths such as suicide or child loss or murder? So at this point in the talk, I'm going to turn this over to Susan, who's going to take us on our bus to this collectively inspired utopia. And she's going to describe for you the visioning exercise we use to develop vignettes that would signal a grief literate society. How would we know if we were grief literate? And to think through some educational and practice implications of this work. So with that, I thank you for your attention, and I will see you shortly in the question period.